Okay. Good evening, everyone. Sorry for the delay because we have some technical issues and we're still having it, but we're going on with it. I'd like to welcome my friend, Dato Professor Dr. HANAFIAH.
Adoy.
Aduh, sudah semakin panjang lah.
Yeah.
To me, he's just HANAFIAH. I've known him since first year in UKM. After that, he went to UK to study, right, Khan? Kita
Yeah, that's it. Yes.
UKM. So we have come a long way. I think so. We have known each other maybe 30 over years.
Mm-hmm.
And of course, he has gone up the ladder, and he is also the pro vice chancellor. Is it pro?
Yeah, that's right.
Okay, pro vice chancellor, which is actually amazing. Right, almost at the top of the hierarchy in academia. And so without further ado, let us try to go on with this talk. So HANAFIAH, let's go.
Okay. Thank you very much, Betty, and good evening, ladies and gentlemen, everyone. And I really apologize for the delay. I don't know what's gone wrong, but I had these slides which uploaded, unfortunately, although I can see it very clearly on my screen. I was told that you can't see it from the other end. But anyway,
we can see a slide, but we can't see a slideshow. Yes,
we can see a slideshow. Okay, that's at least you have something.
Slide, yeah, that's right.
So I will try to do my best to. I was told by Betty to make it informal, and I am happy to answer any question that you have. I'll try to make it as simple, as easy as possible, because I don't think it is meant to be too highly scientific, because then it will end up with a very small niche of people with the interest of vascular surgery to actually then benefit from it. I'm just hoping that we can share, make it as easy, because when it's easy, then it's easy to remember. When it's easy to remember, then it is easy for everybody to practice. If it's easy to practice, then I think we achieve our goals of delivering the service to our patients that we would like to serve. Betty have kindly given the introduction. I'm not that high. I'm just a low worker. I'm still in the hospital here. We're all together. We are colleagues. We all have our own roles. I don't think we should have too many hierarchy, because all of us have got our own duties to do. Of course, some others have a bit more experience than others, but you know, we are all colleagues of the same level. Kalau nak cakap pasal puji bagus, Betty was our top student in class. She's I'm sure the cleverest, one of the most cleverest person that I've ever met. So I'm sure she's still the cleverest in class if we actually test each other.
You know, man. Okay, go on.
So I will just continue with my talk. Now, I was told to actually give a talk on vascular assessment and the need for early referral. So the need of early referral is very apt, very timely. Vascular assessment is something which I don't think is too difficult if it's done properly. But unfortunately, everywhere you go, not just Malaysia, everywhere we go, it is not something that everybody is quite comfortable or confident with, because it is not commonly shown or done, you know, in many practices, because vascular surgery has been seen as a subspecialty, not only a specialty, is a subspecialty. And even in the UK, whenever people have a vascular disease, they tend to be referred directly for vascular surgeons to assess So the responsibility has gone to another group of people, and hence many don't quite feel comfortable looking after people with vascular diseases. Number one. Number two, the stake is very high. If you make mistakes, you wrongly assess. People are worried about getting sued, complications, and so on and so forth, and hence people less likely to take that responsibility. So here, I hope that we can share this. It is easy, it can be done by everybody, and it is rather straightforward, and maybe perhaps we can look at telltale signs, who and when to refer to. We know that the vascular disease in the Western world is rising. This is when you read any textbook, we know that people are getting older. There is a lot of problem with obesity, poor diet, diabetes, and bad habits. Yeah, bad habits such as smoking and so on and so forth. And we know as well that occlusive arterial disease is associated with a shortened survival. But even when I was in the UK, I was there for 16 years. I had the impression that there are less vascular disease in this part of the world. It is more common in the Western world. But when I came back, it is not true. We still got lots of people with vascular problems. Perhaps it's not been properly documented or picked up. Perhaps we actually have the wrong sense of security. When you look around you, if you look hard enough, you will find people with vascular disease. If you have high incidence of heart disease, high incidence of renal vascular disease, cerebrovascular disease, peripheral vascular disease will go along it as well. Next slide that I will share. We know that the major risk factors are similar to Betty's patients. Smoking. Usually we ask, what are the risk factors? Ask my students. The first answer is smoking. The second answer is smoking. The third answer is smoking before you go to hypertension and hypercholesterolemia. But in Malaysia, almost 100% of our patients have got diabetes. This is where we are different than the Western world. That diabetes has come up the ladder to be one of the major causes of peripheral arterial disease. It has a different pattern than the one that caused by the risk factors above, which I will share later. But again, we know that people with diabetes will have a problem with their vasculature. So we need to look hard among the patients. We know that the problems related to the foods remains the most common cause for hospitalization in diabetics. Yeah, they have lots of problems, but the one that causes hospitalization are related to food, not just vascular disease. The neuropathy problem, the Charcot's food, and many other problems are related to diabetes. But again, peripheral arterial disease is high among them. And 60% of non-traumatic limb amputations are diabetics, although they comprise only 7% of population in the USA. We've known this already, that the incidence or the prevalence of diabetes in our part of the world is high. We using the 2018 figure, 3.6 million of Malaysians are recorded to have a problem with diabetes, and is predicted, in just a few years' time, by 2030, even before then a third of our populations can be considered as diabetics, and 75% of amputations in this country are related to diabetes mellitus. And Malaysia has spent a lot of we've got restricted health budget, but 13% of our health budget was spent on chronic diseases that includes diabetes as one of the major disease. Now, we know that silent peripheral vascular disease is prevalent in people with diabetic neuropathy as well. This is the problem with diabetes as compared to the Western world. The Western world, their skin is fair. They got a little bit of bluish discoloration. You can pick it up. When it's cold, you get symptoms exacerbation. They will have cold feet. They will start having some symptoms. When they walk, they get claudication, they complain. But when the diabetes is the cause of it, it is not the proximal disease. They got a distal disease. They are related closely to diabetic neuropathy, so they don't feel it. And hence, unless you actually look for it, you feel for the pulse, you look for all the telltale signs, you might miss it until it's a bit late. So this is why we sometimes find that our patients present late, and therefore by the time it reaches the vascular surgeons, we have very little options to actually save those legs. The prevalence of peripheral arterial disease in Asia among diabetics can be quite high, but I say there are not many papers. Some are underreported, as you can see it here. So we should take it as a pinch of salt. But we know that one of the major papers that's been presented, that's been published in Malaysia, 4.3% diabetics are amputees. It's quite a big number. Many of them never get their prosthesis, and amputation reflects the state of our health service, because if you have a good system, you pick it up early, you can prevent amputations. Therefore, it gives you an idea of the kind of service that you give to your community. If the amputation rate is high, therefore you need to improve the system. Why do I call? Why is this topic important? Why does Dr. Betty ask me to speak on this? Because if you fail to treat, this is usually the end result. If not the patient's life, the patient's limb, one limb, two limbs, very difficult. They will lose their mobility. They will need carers at home, and so on and so forth. They will have some mental what they call this, a disease, i.e. they get depression and so on. They lose their self-esteem. And if you actually treat them early, some, not all, some of that, despite big non-healing ulcers and wound like this, it can be cured if you manage to intervene them early and appropriately. We look at some definitions before we move up to what do we need to do with them. Ischemia is a Greek word, means the restriction in blood supply, generally due to factors in the blood vessels. Why I say generally due, because there are some other causes not within the blood vessels. You can have external compressions and so on and so forth. You can have trauma, but restriction of blood supply, for this purpose of our talk today, is generally due to factors within the blood vessels, maybe within the wall or within the blood itself. And the presence of stenosis or occlusion. Stenosis means narrowing, occlusion means completely blocked of the major blood vessels or arteries of the limbs. And this can be manifested by the ankle brachial systolic index of less than 1, which I will show you later. Yeah, and the pathophysiology, if you speak to somebody like me teaching at the university, you always like to go to slides like this, pathophysiology, to understand the disease. You know that the formation of atherosclerotic plaque due to the risk factors I've mentioned earlier. Then the development is a slow process. It doesn't happen overnight. Slowly you build the atherosclerotic plaque until one day it is narrowed enough and the blood flow is so slow that thrombus is formed and you get a complete occlusion. And that is manifested from the symptoms and signs that you will find from the patients. But if you look at the physiology, earlier we looked at the anatomical and the pathological process. The physiological process is that the turbulent flow leads to loss of kinetic energy. So if you have 50% block, the flow reduction is more than 50% because it has slowed down, causes turbulence, and you have lost that laminar flow. So it is. So you will find that the 50% block may cause 70% reduction of blood flow and so on and so forth. So it is important to pick up at the appropriate time and treat it accordingly if it needs to be. Looking at just the pictures of X-rays, angiograms does not necessarily tell the whole story about how much blood supply that reaches the distal limb. Some risk factors. Why I share the risk factors? Because this will make you aware, so that you can then target a certain groups to actually do your screening. So whenever you see your patients in the clinic, perhaps some risk groups may require some careful attention to their vascularity. One is the male sex, although female is now catching up with that. We know people with higher age, the older they are, the higher the risk of getting peripheral vascular disease. There's no surprise at all as the vessels undergo degenerative changes. Diabetes is a major factor. So people are diabetic, they are male, they are old age. You need to have a suspicion. So whenever they complain about problems in the legs, don't just leave it to arthritis, gout, and so on and so forth. Have some index of suspicion that they may actually have some problem with the circulation, particularly if they are smokers. And when you take the blood pressure, they have a history of hypertension, and it's shown when you check their blood pressure and you check their lipids. The lipids are also high. The other thingy here maybe sometimes are not so common, like hyperhomocystinemia and so on and so forth. But renal insufficiency is quite common. So people with CKD, people who are diabetic, people who are smokers, male gender, old, hypertension, dyslipidemia, I would think that they should routinely get their blood vessels checked. The risk factors are synergistic. So if you have one risk factor, that is your risk. You have another risk factor, it's not 1 + 1 is 2, 1 + 1 is 4. So one risk factor, two risk factors lead to a cumulative effect to have a higher risk of having the peripheral arterial disease. Now, the manifestation of atherosclerosis is found more than in one arterial bed in individual patients. So if the blood vessels are not confined to just one organ, so if you have disease in one organ, therefore you should look it in other organs. So people with coronary artery disease are more likely to have peripheral artery disease as well, and they're more likely to have a cerebrovascular disease as well, and 3.3% have all the three, which is actually not a good sign for those patients. And majority of them, if you follow up their cohort, we'll find that they will die of some form of a cardiac event. And a lot of our patients actually suffer from that. So why is this important? Because when you actually assess them, you will have to look into two endpoints. You want to treat their limbs. You also want to actually treat their cardiovascular risk factors, so that you reduce the cardiovascular events. Simple take-home message. I stop here for the time being. When you look at that, this is actually should be the last slide. But anyway, the ABC of managing peripheral arterial disease, whenever you check them, A for HbA1c because they are diabetic. Check for the HbA1c, check their blood pressure, check their cholesterol, and C, also check their circulation, and you should not be too far off from what you are supposed to do. Who you should assess? You should assess all of them with the risk factors. People with diabetes needs special attentions with some additional features, which I will discuss when we reach the next slide. But you should go back to the basics, take a good history, do a thorough clinical examinations, and then appropriate investigations either at your clinic or can be added at some specialized centers that has got the facilities to do it. you identify the patients, like I said, with all the risk factors, as I said, mentioned earlier. Any patients with coming to you with a complaint of what? Exertional leg pain, i.e. intermittent claudication. They present to you with cramps whenever they walk a distance, and it's relieved by rest, almost like an angina, but it's angina of the leg. Patients that is more than 50 years old with diabetes, who smokes, and of course the patients with all the risk factors above 70 years old. If they have a previous history of TIAs, the history of non-controlled hypertension, renal problems, and so on and so forth, with a diagnosed coronary artery disease, these are the patients that you need to be aware of and do actually take the trouble to actually assess them appropriately for their arterial disease. The techniques are, as I said earlier, medical history, physical examination, and then some diagnostic tests is appropriate. When you do the lower limb examination, look for some telltale signs. Look for some hair loss. This is not easily seen or easily appreciated, because it is always talked about in the textbook, but as said, we are Asians, you know, many of us maybe do not have too much hairs down the limb, so you can't appreciate the hair loss. But you can see some evidence of brittle nails, especially when right leg and left leg has got a discrepancy between them. There's some atrophic skin. There are some, the dependent rubor means they actually, if somebody who's fair skin, they looks dusky, it looks reddish, but it's not hot, it's actually cool. And when you lift the leg up to about 15 degrees or 30 degrees up, you will find that suddenly it goes pale, and you got what we call the guttering of the veins. It suddenly forms like a drain, the vein sinks and dips inside. So so that is again a telltale sign that, so if you lift it up, you leave it for about 1 minute, the color change, and when you hang it down, the color return. If you see any signs of tissue loss, ulceration, gangrene, these are actually quite a hard sign that you can actually say for certainly this patient has got some arterial problem. You can also listen. Unlikely you're going to be able to hear for any bruit or feel the thrill down the limbs, although it's been said, but I find the flow is too slow for you to be able to appreciate it. But if you listen to the abdomen, if it's a proximal disease, the flow is high there. So if you have a stenosis, you will be able to appreciate some sounds of bruit. These are some of the signs that you can actually pick up. You see some, this is a wet patch of gangrene. You can see the skin has undergone necrosis there, and then there's some cellulitis surrounding it. This again is not uncommon. It's due to some pressures, particularly the patients who sometimes had stroke. You don't look after the pressure areas, and then they already have some form of decrease in blood supply down the leg. So these pressure areas can undergo some skin necrosis. This is more likely to be an acute on chronic problem. If you get an acute occlusive disease, you will find the leg suddenly has gone swollen, and then you can see some blistering down the skin because of ischemia. And this is actually a bad sign. If you see this cold leg, swollen, very tense, painful calf, then think about a critically threatened limb, and you need to contact somebody who can actually deal with it in quite an urgent manner, because usually you've got between 6 to 12 hours. Beyond 12 hours, it has become irreversible.
What can you do about it?
Here, you actually have to assess A, if the leg is still viable. You can see the viability, i.e., either they have a fixed or non-fixed mottling. If the foot can still move, there are some muscle movement there. You can still feel it is below grade 3, is grade 2, maybe 2A, 2B, acutely threatened. So it is still viable. You check the CK, it's not very high. You need to do an urgent angiogram and see where's the problem, and you can see, and hopefully you can revascularize them, and also look at the muscles and do a fasciotomy. You can save the leg if you get it timely. If you actually leave it too late, the leg is already dead. They came in, there's no movement, there is no feel. CK is over 30,000, then the muscle is already dead. If you try to revascularize that, they will cause systemic problem. The patient will become hypotensive. They go into acute renal failure. So this is what we have to deal with. This is almost like your MI, but it's actually happening outside, so we can actually see the tissue undergoing necrosis.
I had a case like this before. I will talk about it later. Okay, go on.
Boleh, nanti later we can talk about it.
Yeah.
Feel the pulse. So how do you assess them? I just thought, this feeling for the pulse is, it's a skill that has been learned long time ago. So if we fail to do it, today we've got a lot of technology, but it is a basic in medicine that we all have to actually learn how to do. So for the lower limbs, there are areas that we feel for the pulse. Why do we feel in this area? So one is the popliteal, the other is the femoral, and then you look at the crural, i.e. posterior tibial and dorsalis pedis pulse that you feel. Why? Because these are the areas where they are most superficial. And number two, behind that, there is always a bone, which makes you be able to actually press on it so you can feel the pulse. All the other areas, they actually dip in the muscles and you can't feel the pulse. So it's difficult to compare. Yeah. So you need to know a bit of your landmark, at the middle inguinal point. You have to, for the knee, what you have to do, you have to bend it a bit. Don't bend too much. You bend too much, it's deep in the popliteal fossa. The artery will go, it's a deeper structure in the popliteal fossa. The artery will go very deep. You bend it too much, more than 90 degrees, then you can't feel it. You don't bend it. If you keep it straight, then you taut the popliteal fascia. You can't feel it because it stops your finger. So you usually soften it a bit, and you put it. I usually like to let the patient relax the leg, and I lift the knee to bend it, not the patient's trying to bend it. And I usually between 15 to 30 degrees is actually good enough. Here's for the posterior tibial, is behind the medial malleolus, is behind because anterior to it is your greater saphenous vein started. So it's behind it, so you should be able to feel it. And then you should also go for the dorsalis pedis, is between the first and the second web toes, the metatarsals. Yeah, and don't forget, this is sometimes what we forget to do. So always remind ourselves, remind our staff, have a look in between the toes, because that's where you're going to find the crevices and so on. And that's perhaps the first subtle sign that you will find for patients who will get problems with ischemic and gangrenous toes in the future. So having done the simple basic pulse examination and record it, you can do now some non-invasive tests if you have it in your clinic, which is good. It's a simple Doppler machine. Then you can actually put in the cuff and then listen to it. There are other tests like duplex Doppler ultrasonography, MRI, or all these are subsequently more technically demanding. Some of you may actually have the skills to do the duplex Doppler ultrasonography in the clinic. That's fine. Otherwise, you may actually have to refer to facilities that has all the others. But these are some very basic things. the Doppler machine are not too expensive. Maybe you can afford to have it too. Good to have it in the clinic. Put it in the right place, and then you can hear the sound go whoosh, whoosh. And then you just need to put the cuff at the ankle, and that is actually then you put the pressure to occlude it up to about maybe 20 degrees above your systolic pressure, so that it disappears, and then slowly let it go. And the time when you hear the returning of the sound is the Doppler pressure you want to take at that particular blood vessel. So you can record the ankle brachial pressure index. You compare it with the brachial pressure that you take usually like you normally do with blood pressure. Yeah, so you compare, and then you can do the so one in the arm and one down the leg, and then you put the ratio, and then the ratio should be actually, it should be more than one. You expect down the leg in a normal person like Dr. Betty, it probably more than one. If you do 120 in the brachial, it will be probably 130 down the leg, because the resistance is higher, it's going down the leg with so you will find that it probably is a little bit so 1.1 is somebody very normal. So 1 is okay. Below 0.9 is considered you already have some reduction in flow, therefore you'll be a bit suspicious they have peripheral arterial disease. So the sensitivity is very high. If it's done properly, sensitivity is very high. It's very specific as well, and repeatedly, people who do it regularly, you probably get a repeatability of this test, and quite reliable as well. So anything below 0.9 is considered abnormal. Anything below 0.5, you will find that they are already usually beginning to have what I consider as a critical, they're going into critical limb ischemia, because they would probably begin to get very short distance claudication or start going into rest pain, and by below 0.3, you will probably lose some tissue. But remember this, anything above 1.4 is also abnormal. So sometimes people get very happy when they say, wow, very high. I put 180 also, I cannot occlude, I can still hear the sound. That's also a bad sign. Why is it a bad sign? It means there is already a hardening of the artery. You cannot occlude it. When you actually put the cuff, it does not get occluded because the artery wall is so hard already. Doesn't mean there is no narrowing. It's just that you cannot occlude it. So how do you know? Because a lot of these patients have got this problem because they are diabetic. So what I do usually, this is another trick. You don't find it in textbook. You put your Doppler there, you can still hear it. You may actually find that the sound is no longer triphasic, it's go to very low. So you just lift the leg up. If you lift the leg up maybe 15 centimeter above the ground, yeah, just lift the leg up. The sound should not disappear if it's normal. You really can lift it up to maybe almost 90 degrees, you should still hear the sound. But if after 15, you lift it up maybe 15 centimeter, 20 centimeter up above, you already see that the sound disappear, despite you cannot occlude it, that is a bad sign. You will know that it's already that the patient has got a peripheral arterial disease, despite their ABPI of high. So you can do that. Now, in a busy place like ours, we use the pulse width velocity machine, so you can do that. But if you've got 100 patients a day, then perhaps you can actually invest on something a bit bigger. There's a machine that you just put it there, you just press a button, and it gives you a report. So it calculates for you using the pulse width velocity. So this is quite good. It's pretty accurate as well, and it gives you more than just that. It actually do some other measurings too, and put it on the graph. What is good is that usually the patient is very happy if it's normal, because they have got some like a certificate. They can go home and they come back in 5 years time to say, can I test again? So they always like to get some form of a clean bill of health So you can actually use this. Otherwise, maybe it's not, if you actually don't have as many patients, you may not want to invest on something like that. You can also do some toe pressures for those diabetics that have high ABPI, but has got ischemic problem because they also have some microvascular disease, not just macrovascular disease. I'm going to move a bit faster from now onwards.
Okay.
Here you can do some duplex Doppler sonography if you have the skills to do it. You can actually the advantage of which you can actually now localize the region and you can actually calculate the level of stenosis. You can then subsequently, if those patients that requires this, you can do a CT angiogram or MR angiogram. MR angiograms tend to overestimate the stenosis. CT angiogram is something which is easier to do, is faster. Most hospitals have got it. MRA has got a longer waiting list. But again, it depends on what you have. These are quite good because they are non-invasive, because the gold standard is an invasive procedure. You really have to be like the cardiologist. You have to puncture the patients. The good thing about it is that if you see a lesion that is actually treatable by angioplasty and stenting, you can actually deal with it at the same sitting as well. So it can be therapeutic, whereas the MR and CTA are just diagnostic. So this is some of the pictures you can do, you can see when you actually do that. Then you can classify this according to the task classification. You don't need to remember this, but task A means there are just one single lesion, they are not so tight. Task D, there are some occlusive disease, is a severe disease, and maybe multiple level occlusion. And you should also think about the pattern of disease. Diabetic has got microvascular disease on top of the macrovascular disease, so the disease can be very distal, so it's difficult to treat, whereas people are smokers and non-diabetic tend to have a more proximal, particularly 90% of them in the femoral popliteal lesion. You can do x-rays as well. X-rays for diabetics is important because you can see there's some gases down there. So when they have a gangrene area, you can see some gas. Perhaps that needs, there's an abscess formation, you need to drain it. Sometimes you can also see calcification of the blood vessels. It tells you the state of the legs. But don't forget to look at the skins, the overall picture, the patient's self, whenever you examine them, correlate with your clinical finding. You can then use either the contain or Rutherford qualification. You can then grade them because obviously that the treatment and the urgency of the stage 1 is not the same with the urgency of those with stage 2, 3, and 4. Problem with Malaysia, late presentation, not just the SEA Games players. Malaysia boleh, our patients also boleh datang lewat, and a lot of time they expect us to actually do some magic and cure. Occasionally, there's nothing much we can do apart from offering them some amputations because it's just too late. It's just too late and the tissues are dead. We can't bring back something which is dead. There are lots of reports and recommendations what we should do with them. Vascular surgeons, I put in a picture of the late Mr. Zainal, who's I think most of us who's been in vascular service know, and a tribute to him. He actually started a huge major program in the hospital Kuala Lumpur. A lot of his trainees are now everywhere, but we are still very short. In the National Specialist Register, we've only got 29 registered. They are scattered around the country. So if you are in the Klang Valley, you may want to refer to some of these centers. But if you are outside the Klang Valley, it's a bit more difficult to get a specialized vascular unit to actually deal with it. So a lot of these vascular patients, because of the numbers of diabetics, have to be dealt with people who are non-vascular. And a lot of things can be done even without the vascular surgical intervention. Vascular surgeons may come at a very late interventional stage if it's required. These are some of the things that I just want to share with you that you see, when you open up the blood vessels, you can see the plaque there. We like to play with blood. We like to stitch. So this is what we do. Whenever we set up to see a patient, we want to treat them, look at the two goals, the LIM outcome and the CVS outcome. There's no point we can't operate on everybody. Sometimes they're not fit to be operated on. And if we operate on them, you may save the leg, but you may lose the patient. They will die. We actually work very closely with our fellow anesthetists and physicians on what to do with the patients. Here, again, I will go very quickly because that's not the aim. I just want to show things that we can do at this end so that you understand the need for early referral. Sometimes patient may ask you, do I need to go? Do I see? Can you save the leg? Nothing can be done. I see somebody being referred and then they end up being leg potong or mati, so I don't want to go. So yeah, you can actually treat them early if they are early stage. You do some risk factors modification, non-pharmacological or pharmacological intervention. You can revascularize them whenever is appropriate, either by operating or endovascular means, or in some late stage, you can amputate them. This is probably the gist of the slide. Yeah, for risk reduction, lifestyle modification, stop smoking, weight reduction. You all know this already. I don't have to go through this in detail. If they are diabetic, treat their diabetes aggressively. If they have high lipid, you want to treat their dyslipidemia. They have hypertension, treat the hypertension. You all have to do this. And once you find that they have peripheral vascular disease, you must start then on antiplatelet therapy. It's been shown, and this is highly recommended. Yeah, they should be on antiplatelet therapy, and they should be on statin as well. Invasive, intensive and aggressive treatment for their risk factors has been shown to reduce the primary morbidity of the disease. Statin is also sounds to be favorable. You can then control their blood pressures aggressively. Clopidogrel has been shown to be more effective compared to aspirin, but again, aspirin is still the first line has been used in the treatment for people with peripheral vascular disease. Drugs, there are many drugs has been tried, but the only one that works is we find is Plital, Silastazole. The rest did not show enough evidence to show it make change, any changes to their claudication, but a exercise program, aggressive exercise program, not the one you just tell them to just walk. We actually do a systematic exercise program has been shown to improve the claudication rates. Those that you want to intervene are those who actually have a risk to the leg. They either have rest pain, their ulcer doesn't heal, they already have gangrene, and or maybe in certain group of patients they have a lifestyle limiting claudication. Yeah, these are some of the parameters that you want to actually start intervening. The ABSI is low, and the absolute ankle pressure is low, or they have any evidence of tissue loss. And ideally, you want to heal their wound. The procedure must be uncomplicated, as a lower risk as possible. And then there is no need for a repeated procedure. Then you can either use endovascular techniques, surgical reconstruction or amputation, and you look at the limb viability versus the patient comorbidity. So aortic disease, you can either do a bypass graft. We used to do this when we were registrars. Nowadays, we got very good interventionalists, and the results of endovascular treatment is as good and as durable as the surgery. So you'll find that there are less and less aortofemoral bypass graft has been done today. These are some of the things that we used to do. You see less and less of them. Whenever the patient is not fit for aortic clamping, we actually use extra anatomical bypass such as axillobifemoral bypass here, like we do. So percutaneous intervention has been good. You can usually find that with the skills that we have, we can actually open up some of the major blood vessels. FemPop segment, there are people who actually attempted to do endovascular means. I think the result is still 50-50. We got the basal trial that has been shown that if you have a long disease, then perhaps bypass is better for durability as compared to angioplasty, but short disease, it works. Patients who's fit probably should have a bypass. Patients who's less fit then should undergo angioplasty. Tibial disease, bypass may have a better results. Angioplasty going down stream not have a durability as much as a tibial bypass. Here are some of the pictures that we have, but we've done right down to the ankle before with some success, but they tend to get the restenosis back in the future. This a patient who actually almost been amputated 3 months of a non-healing ulcer. The orthopedic surgeon wanted to amputate. She seeks second opinion from us. We actually did angioplasty of the proximal disease. She got multi-level disease. We actually put the bypass right down to her ankle. We actually then put a skin graft, and 3 months later, she managed to heal. But after being 3 months in the hospital with some rehabilitation, but she's grateful, ever grateful to us, because she doesn't want an amputation. She's quite young. I think she's in the late 30s or early 40s. You can use some stents. There are various types of stents. Some are drug-eluting stents and so on and so forth, very much like the cardiologists use. Different type of balloons, atherectomy device has been used. Cryotherapy has been used. These are all the newer things, and we have that trying to help to prevent amputations. And we know that revascularization rates actually reduce the amputation rates in many of the papers that has been presented before. But beware, sometimes it's not just the ischemia. Sometimes, particularly in diabetics, is superimposed by infection like this. So despite you manage to actually revascularize the leg, but there are too much infection there, there's no point. So the patient may still lose the legs because of infection and not because of ischemia. So we have to remember that. And at times, we probably best to just do an amputation with better result than multiple small intervention subsequently end up with the patient having stayed in the hospital for a long time and has got multiple other complications, including pneumonia, DVT, and so on and so forth. Just a word reminder, this patient had some minor problem, and amputation was done to the toe, but when for dressings and the dressing was too tight, was referred to us. When we open the dressing, then you'll find that those other areas of the legs, which is actually initially not affected, has become ischemic. The patient ended up with a below-knee amputation because it was wrapped too tight for 2 days.
Oh my God, so sad.
It's very sad. Patient come from Malacca. So the leg, it was just a toe, but end up with losing the whole foot. Yeah. So ini pun kena ingat jugalah. Sometimes you try to help, but you end up losing more than what the original presentation. There are many other adjunct and newer therapies that have been used. I just share here. Slides can be shared. Later, you can maybe get it from Betty, because we're running out of time. We do some stem cell therapy here. There's a Professor Higashi that came from Hiroshima, come and work with us. So we have now done quite a bit. This is our first patient, again, 3 months history of non-healing ulcer, almost needing an amputation, referred to us. We found there is no revascularization option because it's so distal. So we actually then attempted, so we took his own marrow, we culture it, we spin it, and then that's me injecting it in the grid. And Professor Higashi happy, I'm happy, we managed to do it. Is patient happy? This is his leg, no blood vessels down the ankle. Subsequently, later, we'll find that 6 weeks later, we actually begin to see new blood vessels formation right down to his foot. And there you are. If you remember this earlier, just 6 weeks later, he's actually managed to heal. So he's very happy.
Yeah, the stem cell into what?
We inject the stem cells into the muscle, along the line of his blood vessels. So into the calf and around 2 areas around the calf, along the line of his anterior tibial and posterior tibial vessels. And then we also injected into just surrounding the ulcers. So we were surprised. And
I see.
and we've produced papers now. We've got quite a number of patients, and we have actually then published it. The patient is so happy. One thing that we realized that his neuropathy is also gone. He just told us, "Doctor, dulu kebas, sekarang sudah hilang, boleh rasa balik." So that is something surprise. So we haven't studied that. We want to look whether it helps. Now, there are some patients that we actually tried some all the other stuff, stuff. I don't think it's routinely done, but we use these hyperbaric chambers. It actually worked with her. It got clean, but in the end, we actually still have to skin graft this. So in brief, I just want to summarize things. The PVD is increasing. If it's not like COVID that actually caused the whole world to call it a pandemic, but probably there's more people with PVD than people who actually died of COVID. So so we've got to put in perspective. We need to take it seriously. A lot of people with all the risk factors that we know, they will have this problem. And if you look at the papers by Leshmanan tadi, 4.3% diabetics end up with amputations. And we know that maybe 30% of our population by 2030 are considered diabetics. So considerlah berapa ramai orang yang mungkin end up, if the rate is still the same, with amputation. And this is a big problem for the country because we need to look after them. And so it is our duty to actually prevent them from getting this problem in the first place. But if you can't prevent them, you try to detect them early so that we can treat them early to prevent the problem. So I think I'll stop here.
Okay, we have some questions, but I am very impressed with the stem cell treatment. I am not just impressed, I'm amazed.
Yeah, but we still do it under a very controlled environment. So because we don't go out and just inject everybody, we actually put them on a trial for those who are suitable. And then, but we are very happy with the results. I have to say,
because
Prof. Chin.
You have managed to establish new vessels. I'm not sure whether it's new vessels or the old vessels opening up. But
they're new vessels. On angiogram, it's new vessels.
It's new vessels, so it's like collaterals.
Yeah.
Okay, it's amazing. It looks very good. So we have some questions, and one is from Dr. Chan. Dr. Chan asked me, I know, is there any open surgery for triple A?
Yes. In fact, we've just finished one. So yes, definitely.
Yes.
Triple A is still common, and we just had one case earlier today come in with abdominal pain, and we found to have a leak. Yeah, so we have to take to OT. So yes, the answer is straightforward. Yes. So pick them up.
Yes, triple A is not as common as you think, but it's not as rare as you think either.
Correct.
Yes, peripheral vascular disease, I find that it is a very difficult disease to treat. When it has come to that stage, it is painful, it is very disfiguring and very difficult for patients to carry on the usual activities. But what's most important is that to do vascular non-surgical treatment, it is very expensive. The stents are very expensive.
Correct.
Isn't it? It's much more expensive than cardiovascular stents.
Yeah. Unfortunately, it is expensive. It's a highly specialized area. So it's well controlled by only a certain industry that produce it. So it's expensive. The best is actually try to prevent them from getting the problem in the first place.
Okay, Ashwin asks, is there any role of prophylaxis patient with diabetes, hypertension with picogenol for prevention of peripheral vascular disease? So he has quoted some papers here, but
to be honest, I've not used it. I am not sure any of my colleagues use it. So if you have quoted some papers, maybe I can have a look at it and see. It's not in our guidelines. It's not a common. maybe there are some, experimental. There are new things that come up over the last few years, I think the jury is still open. Even if there are evidence that certain drugs that works, earlier I put through that, there are many people trying to use various drugs for peripheral arterial disease, claudication, but when you follow them up, you will find that there is no difference with the placebo, or the difference is so small that doesn't make economic sense to actually do it, and it doesn't change the overall long-term outcome of the disease, which means that if you follow is a lead time bias, eventually they will end up needing whatever is done. It doesn't help. The drugs that actually been definitely in the guidelines that has been shown to be categorically should be given are the antiplatelet treatment and the statins. That is beyond doubt in all the guidelines we have. Many other drugs are actually used to for perhaps are vasodilators and symptom control drugs. Even like you probably being familiar with the Rosuva statin at some point, said to be able to reverse the atherosclerotic plaque, but subsequently later is not so. So all these new drugs, I would be very careful about giving them routinely until we have long-term results to look at the efficacy.
Yeah, I think the take-home message, what he's trying to say is, we have available drugs which have very good studies, and very easily accessible to patients, that you should always think about, and that's statin, antiplatelet, and of course the fact that you should control diabetes very well. So he asked, how do you screen patients who are eligible for stem cell therapy? I also would like to know that. The cost covered by the government, or the patients have to pay?
Yes, if they come to our place, because we have research grants, so we use the research grants. That's why we do under the research wing, yeah. So we use the research grants to actually cover the costs. How do we screen? We have strict protocol. The patients must, these patients, if they have any treatable lesions, they must undergo those treatable lesions first. For example, if you can do bypass, you do bypass. If you do angioplasty, you do angioplasty. So we put them into those category, those lesions that we cannot go because they're beyond. They are quite distal. No, proximal disease, you can't open up big blood vessels from stem cell. They actually open up the smaller blood vessels. So you bring the inflow first, bring as much blood down the leg, and then for those that you can't actually do anything about because they are microvessel disease, you inject those stem cells so you can open up the blood vessels. So it's an additional procedure. At this moment, that's what we do. So we screen them. So if everything else have been used, then you still find that the ulcer, usually we make sure they have critical limb ischemia, i.e. by definition a non-healing ulcer, slowly non-healing ulcer, and then or evidence of tissue loss, gangrene or whatsoever, a toe, so we actually are very careful. Number two, no infection. So this is very good for people with Buerger's disease. Diabetes, you have to be aware of, because you want to put in these cells into somebody who's got an abscess down there, inject them, you may spread the disease, so we don't want. So we actually screen them to make sure there is no infection that you need to drain. Of course, there are some other group that we are aware of. For example, if you have neoplasm, you have tumor somewhere, and then you have this ischemia, we don't want to put these stem cells, which potentially are multipotent cells, and then if you have a tumor in the body, they may actually produce some tumor growth factors whatsoever. You never know that this stem cell may grow into something else instead of blood vessels. So we are very careful in that. Yeah. So in short is that this patient has got a treatable lesion. but we have tried everything else, it doesn't work, so we do that. But if you are not part of that trial, then each injection costs you 30,000 ringgit. So that's going to be quite expensive because of the things that we have to do to actually culture the cells and extract them. Plus the wards, the the ward charges, the procedure charges, blah blah blah. So it may be quite costly. But to culture the cells, 30,000 ringgit per injection. So it's quite expensive.
Okay, and I ask, Prof, can patients with peripheral vascular disease present with compartment syndrome?
Yes. The short answer is yes. They can present with compartment syndrome, particularly if they have an acute thrombosis of a pre-existing stenosis. So say for example, your anterior compartment down the lower limb, down the lower limb, the anterior compartment. So you already have a stenosis there, and then suddenly, because your blood pressure drops, because for whatever reason your platelet is high, you undergo acute thrombosis. Therefore, the muscle undergo ischemia, it will swell because it's an acute ischemia. There is no collaterals. It's an acute ischemia. The muscle becomes ischemic, it swells. When it swells, the compartment is very narrow and the sheath is very tight. So you will get intractable pain beyond what you can see from the outside, and it's going to be very tense. If you test the CK, creatinine kinase, it's going to be very high. If you try to actually dorsiflex the foot, the patient will scream like hell, and that is a compartment syndrome. So if you see that, you probably have to quickly do a fasciotomy. If you don't know how to do it, somebody we have been trained need to do it, but it's quite easy. You can do under local. You just slice open the skin and then slice open the fascia to let the muscle bulge. You may save the leg.
Oh, you can do it under local.
Well, we do it under local a lot of time.
Okay. Dr. Gurpreet Kaur asks, what's the longest duration a patient can be on pentoxifylline? Okay, can you explain this pentoxifylline? It's so familiar, but I've forgotten what it is.
Trental.
Oh, Trent. Yeah. Okay. Trental, yes.
Trental, you can give it BD.
Yeah, for pain, to increase the
yes, it's good. It's a membrane stabilizer. It's also a potent vasodilator.
Yes.
It is the only drug that we actually use because its trials has categorically shown that it's actually improved intermittent claudication beyond doubt. The other drugs, maybe you have equivocal result. Some results say it works, some results say it doesn't work. But pentoxifylline, I think it shows that it's actually categorically work, and we actually use it. It's a bit expensive, so we actually use it for only a certain group of patients because we have to restrict the drugs. But it's actually quite good. I give it for as long as they need it. So, but I don't use it as a definitive treatment. For example, I have one patient that came in with a quite severe intermittent claudication that he can't walk. He can't walk, and he is very distressed by it. He doesn't want any intervention yet because I said, oh, no, I don't like surgery. I don't like. So can you do something about it? Yes, program exercise is very good, but he can't walk. It's been stopped by that. So I gave him pentoxifylline so he can walk. When he walks, then he walks further. I say, walk up to the rest, the area where, so initially you can walk 50 yards, then stop. And I say, never mind, just walk again until you really cannot walk and you stop. 4 months later, on the drugs and this, and he's very happy. He can walk now. Initially half a mile, and then after that 1 mile, and he's very happy because all he needs to is 70 plus. All he needs to work is about 1 mile. After that, I don't need to walk further. I'm not going to play football, blah blah blah. So yes, you can give it for a long time, but because it's expensive, I don't think you can restrict. You need to restrict it. But by the time they actually have improved, you can stop it, and then continue their exercise and so on and so forth. unless and they got worse, then you maybe have to intervene and say, well, perhaps at this time, I probably need to intervene and maybe we open up your blood vessels a little bit.
So basically the walking and the exercise is to increase collateral, right?
Yeah, the two theory behind it. One is to increase collaterals. You are right. Number two is also what we call it ischemic conditioning. Even without the collaterals, you will find that the muscles actually suddenly can tolerate the ischemia better, the buildup of lactic acid and so on. So you suddenly can tolerate that better.
Can I ask you, is it really true that beta blocker is contraindicated in peripheral vascular disease? This is what I studied 30 years ago, but I'm not sure about it now.
That is 30 years ago. That's what you and I studied, but that has been theory has been disproved.
Thrown out the window.
Yeah, by about somewhere in 2003, I think what is shown that people need to be on beta blocker. Beta blocker, what it was thought that because beta blocker reduce your heart rate, and therefore people feel that in the UK, you know, they get pain, then the leg go cold during the winter. So you give the beta blocker, it make the cold worse. So that was what they thought, that it was contraindicated. But subsequently, they find that people on beta blocker with peripheral vascular disease has got a better cardiovascular outcome than people with not on beta blocker subsequently, especially when you do operations on them. So lots of time, especially if they have, for example, we want to do an aortoiliac reconstruction, and those people with peripheral vascular disease, our anesthetists will insist that they are on beta blocker at least a week before the operation, because they have lower incidence of perioperative MI. So we put them on.
Oh yes, it's just the same. When we were in medical school, of course, beta blocker was also contraindicated in heart failure, but now it is actually one of the
drugs that you list them.
Yeah,
you should
the
on.
main,
So knowledge keep on changing. Today, what I say is true. Maybe tomorrow you say it's rubbish.
Okay, we'll take a
New evidence will come in.
faster because it's already 10.
Okay.
Okay, in Malaysia, can we offer abdominal ultrasound for male 65 and above for AAA screening?
Yes.
Can
We should. We should. There are many programs overseas that's been doing it, and I think we should.
Yes, actually, we can offer ultrasound screening for a lot of things, because after 65, we can also do ultrasound screening for, you know, liver cancer.
Yeah.
Yeah, it's such. Okay, Dr. Kupri asked whether pinoxyphylline for patients who are diabetic. Do you start patients who are diabetic with this drug? You can, right?
You can give, but as I said, I don't really automatically start them. But yes, you can. You need to counsel them fully, their expectations and so on. If they think the drug will stop their disease, it's not true. It's very much into a symptom control reason. So the most important thing is that you must start them on aspirin, you must start them on statin, you control their risk factors, then you can add any other drug you want to add. It's a symptom control.
Yes. Okay, Dr. Key asked celestazole and pinoxyphylline, which is better?
Celestazole.
Celestazole?
Yeah.
Okay.
Yeah. Yeah.
We have one question from Dr. Rafiq Hakim. How about association of PFD and erectile dysfunction?
What's the association of erectile dysfunction and
your peripheral vascular disease?
Oh, there is an association. This is called the Leriche syndrome. I don't know the actual percentage in our population, but people with aortoiliac disease, people with aortoiliac disease, a number of them will have erectile dysfunction because of a lower blood supply to their pelvic organs. It is a well-known phenomenon. and you will find that if you correct the aortic iliac disease, their erectile dysfunction can return. Not necessarily return, because they may have some other problems related to their nervae irrigantis as well, which actually lies this anterior to the aortic bifurcation. So yes, if it's purely vascular reasons, it will return. If there are some other problems, they may not return. But there is a definite direct correlation. People with Leriche syndrome, so it should be asked. Usually it's a bit difficult. Our population, particularly in an open clinic, they don't want, they feel very shy, and you suddenly ask, what kind of question is this? But actually you are really right to ask that question, because it is a sign of a major proximal arterial disease.
Okay, we will stop here. For all the nurses, please go to Facebook, Beating Hearts page to get the eCert registration form filled up. For the QR code that I just shared, is all for doctors only. So yes, the Q&A is so interesting and so lively. Yeah, I
I'm so sorry if it doesn't meet your expectation.
Oh, don't be silly.
I've said something wrong, but I'm happy to answer.
Yes, I think the
questions,
Q&A was very lively and very interactive. So I just love the Q&A. We are sorry that the slide didn't work, but we could see it well. I think it's time for you to get a new laptop. Yes, please ask your university to get you a new laptop. Thanks very much. Hope to see you soon. Say my love to your dad and mom.
Thank you. Thank you.
Your dad has been my patient for almost 23 years, I think.
That tells you how good she is. That tells you how good she is.
See you then. Bye, guys.
Bye-bye, everybody. Thank you so much.
Thank you.
And I hope you enjoyed it. Yeah, thank you.
Yeah.
Thank you.